Yeah.
You know, you don't have a phone or you don't know how to work the technology.
Yeah.
Vice chair of neurology.
Yeah.
Oh, uh-huh.
And so during COVID, we was very.
Yeah.
We were incredibly
I like
fortunate, a month before. He said the big challenge as a neurologist, how do you judge people size? How do you judge?
Yeah.
Yeah.
Oh, yeah.
Yeah.
I shouldn't get too close. Well, thanks so much for being here. I'm so delighted. We are doing annual videos so that interdisciplinary data competition. First of all, congratulations to all teams who participated and submitted their projects. And the finalist teams here, we're so excited to see you and hear about your project in front of our second year budget. So I'm Margaret, and I'm the Chairman of Professor across and Schools Manager in the Finance Department. And a healthcare economist. I live and breathe healthcare data. I have a lot of which I'm sure many of you do, but we can learn so much from it. There's so much value in it. So we're so excited and honored to be able to do this competition year after year, having our students participate and share their really creative work comes out of these competitions and some of the work gets published. It's really a joy to watch. So welcome to our 5th annual competition. First, I want to have a little plug. We have an upcoming convene conference. And again, I have a suspicion that most of you will be interested in the convene conference as well. And again, this is something that we do year after year through the Business Advancement Center for Health. And 6th annual convene is coming up on April 25. And the theme is always about the intersection of healthcare data and analytics and how can we advance healthcare challenges. And this year's sub-theme, the main focus is about smart tech. So these are AI, ML, data analytics powered technologies, and it's inspired by Minnesota's designation as a medtech hub. So we wanted to advance this dialogue, and we really have a fantastic group of speakers. So we all would love for you to be there, and I know Becky has a discount for you.
We'll email it.
He will email it.
Email you the code, yeah.
To our participants in the data competition. Overview, we started this competition, and it is very key that it's in, Business Advancement Center for Health may be hosting and leading it, but we could not do it with all the other schools that you see here, who are very, very active participants through their faculty, through finding us judges, bringing us data sets and ideas, and students. And we have been collaborating with these teams every year. And I also want to make sure that I share some statistics with you. So we had 17 teams participate this year. So top 4 is here. So again, round of congratulations to all of you. And the other thing that is really cool is that 10 University of Minnesota colleges and schools are represented in the competition as part of the team. We have 19 first-round judges that include both University of Minnesota faculty as well as industry experts who volunteered their time to look at all your projects. And we also have our second-round judges here that I want maybe quick introductions in a bit. Our competition goals is to really promote that interdisciplinary understanding in data. And because it's very unique, healthcare data is very unique, and what you can do with healthcare data is very, very unique as well. So that interdisciplinarity is really a key. Not good, sir. It's not good. So the challenge this year for our judges was a really cool data set from a public use file from Minnesota, all-care claims data set. The students were required to use either the healthcare services public use files or the prescription drug detail public use files, and they could combine it with any other publicly available data sets or any other APCD data sets that were available. And we basically nudged them that through these data sets, they could look at different types of payers, different counties in Minnesota. They could look at stratify their analysis by patient sex and age groups between different prescription drug manufacturers. They could look at specific medical services, and then we let them kind of explore what drove their passion and interest with these data sets, and we just wanted to learn more about what's happening in Minnesota. And the cool thing is these data sets are longitudinal, so they could look at from 2009 to 2021 with the healthcare services public use files. The prescription drug file went to 2020, so we could still get a little bit of a glimpse of the COVID period as well. But again, they didn't have to, but it was available for them. Again, thank you very much to our first round volunteer judges. As you can see, a wide range of organizations here from our industry and community based judges. And then also we have faculty representing different schools. So your projects were judged by a collection of faculty from all sorts of schools. And now we have thank you to our final round judges. If you could quickly maybe introduce yourself very briefly. Haley, we could start with you.
Sure. Hi, I'm Haley Bork. I'm the Managing Director of the Data Science Initiative on campus. I have a background in artificial intelligence. I'm excited to see your projects.
I'm Nancy Wolzak. I'm an actuary, and for 30 years I've been a health policy consultant. The last 20 years with Optum and Lewin Group inside, where we specialize in federal health policy. And I love data.
Not love-hate relationship.
No.
Just love.
Just love. Warts and all.
Hi, I'm Pam Mink, and I'm an epidemiologist and health services research at the Minnesota Department of Health. And it's our data that is the Minnesota Healthcare Claims Database.
Hi, Jim Wilkenbush. I direct research computing, and my area of research is in bioinformatics, specifically phylogeny inference. Oh, I'm sorry. There's more.
This actually been our conference and steering committee for me, and it's too. Yeah, so we have awards, and these awards would not be possible without our generous sponsors. So we have the first place team will get $4,000, sponsored by Data Science Initiative and Research Computing. Second place will be $2,000, sponsored by Office of Academic Clinical Affairs. Third place team, $1,000, sponsored by Minnesota Council of Health Plans. And then the fourth place team will get an honorable mention with $50 gift card per team member. And Becky, do you want to go through each team, or should we go team by team and they present? We do a little introduction.
Yeah, let's do the team
But
by
I
team.
guess maybe we can just kind of very quickly look, just to show you, you're all representing different colleges in each team. This is our team 11, School of Dentistry, College of Pharmacy, Medical School, and School of Public Health represented in this team.
Or team 12 and 11, sorry.
Oh, team 12 and you,
Yeah.
12, sorry, I was looking at team,
The first two, yeah.
yes, team 11 and team 12, okay. And then team 12, School of Public Health. Team 13 is College of Science and Engineering, and Medical School and Integrated Biology and Physiology. Team 14 has Carlson School and College of Science and Engineering represented. And again, very, very many thanks to our sponsors, our distinction sponsors of the Data Science Initiative and the Research Computing, Office of Academic Clinical Affairs, Minnesota Council of Health Plans, and of course, Carlson School of Management. Thank you. And with that, I think we're gonna go in the order of the team numbers. Team 11, oh, I guess we're not. Team 11, 14, 13, 12.
Randomly chosen.
Randomly chosen. Okay, so we invite team 11 to present their work.
Just press on. And then here should.
Hello. Good. So hi everyone, my name is Kenny Tsui from School of Dentistry.
And I'm Gavin Wilson from the School of Pharmacy.
So without further ado, we're just gonna start. I bet all of us have heard the advice about preparing financially for retirement. Yes, I see some nodding. Therefore, we're delighted today to present from expenses to access affordable medication strategies for aging populations with chronic diseases. We'll share some facts and thoughts that hopefully ease the financial challenges and anxieties of aging. So let's delve into this critical topic that affects us either now or in the future, if we're lucky enough to make that day, okay?
So just to start off with, the data source that we're gonna be using for this project was the Minnesota All Payer Claims Database. We looked at the PUF, or the public use files, for the detailed prescription drug database from 2009 to 2020. This was a free database that supports statewide analysis of healthcare costs, quality, and utilization. And we also looked at the 7 chronic diseases and the representative therapy classes, including cancer, COPD, chronic heart disease, diabetes, hypertension, stroke, and kidney disease.
Sir, could you go back one page? Prior slide. Thank you. Thank you.
And what we generated here was a list of the top drugs from that database from 2020. This is the top drugs per the maximum script count for each therapeutic class. So for example, in terms of the analgesics, hydrocodone and acetaminophen had the max number of scripts at 101,647. And in terms of biologics, Shingrix topped the list. And then in terms of cardiovascular agents, we have amlodipine. And then we also have neuromuscular drugs that get patent top the list at #1 in terms of script count. This list changes this slightly from year to year, but from 2020 and 2019, this list remained the same. In 2018, hydrochlorothiazide actually replaced amlodipine in terms of cardiovascular agents. And for hematological agents, Plavix topped the list with over 48,000 scripts that were written. And that one did replace Eliquis as well. And in terms of 2016 and 2017, just a few changes around there. Methotrexate topped the list. Atorvastatin made its appearance on top, and then also warfarin topped the list at that time. In 2017. And then the one thing that was interesting that we wanted to look at was in terms of the drugs and Medicare and the cost per user or out-of-pocket cost. And this chart just shows kind of like the top drugs that we found from 2010 to 2020. We can see. So we see amlodipine, we see that actually from 2010 all the way up to like 2019, 2020, we can see that it actually kind of dropped in price, kind of remained steady a little bit too. And we have Arimidex, actually from 2010, almost topping $4,000, and then that one drastically decreased as time went on. Lantex actually had the opposite effect, where it actually increased in price over time from $356 to almost $3,700 and $4,000 in 2020. Eliquis was approved in late 2012. We see that price up skyrocketed over time as well. So this graph just picks a picture of drug prices overall in terms of cost per user.
Did you look at all into when the introduction of generics occurred?
I did look into the generic, when those did cross the market, but these ones had the top, scripts at the time. So in terms of the generic drug entry, they did make the list.
Is that why the price may have gone down?
There's many factors that could have been, there's decrease in utilization and the introduction of generic, drug prices as well, but that's the decrease. Right. That's a great question.
Right, so for our project, we conducted a comprehensive data analysis using a multiple unit regression model to explore the relationship between the main customer user, that's our outcome indicator, that's the y-axis, and various predictors, including the year, that's the x-axis, main customer user, that's displayed on the number displayed on this little dots. And drug classifications as titled here. Okay, so our findings reveal several significant insights here. Firstly, we observed a positive association between the year and the cost per user, indicating that there's a constant increase in medication costs over time. Conversely, the mean proportion of out-of-pocket fee demonstrated a negative relationship with mean cost per user, suggesting that expensive drugs are often covered by Medicare proportionally. For example, this slide highlights the drug classifications for treating three very prevalent chronic diseases: cancer, cardiovascular disease, and diabetes. Antineoplastic agents exhibited a remarkable increase over the past decade, while cardiovascular agents showed a moderate rise, and endocrine and metabolic drugs remain relatively stable. Interestingly, the mean proportion of out-of-pocket fees was lowest for antineoplastic agents, followed by endocrine and metabolic drugs. However, patients bore the highest burden, approximately 30 to 35%. For the out-of-pocket fees, this is actually significant because I think like before, many chronic diseases are associated with some cardiovascular conditions. So it actually affects the majority of older patients with chronic disease. For broader view, we analyzed the entire 17 drug classifications, and here's the result. You may notice a sudden drop in prescription drug prices in 2020. It's pretty generalized drop. And this may be attributed to multiple factors, including the gradual closure of the Medicare Part D coverage, which Gavin will discuss in detail later. Additionally, the COVID-19 pandemic likely influenced pricing dynamics due to disruption in global supply chains and changes in consumers' demands. In short, this data shed light on the landscape of medication costs and out-of-pocket expenses for older patients with chronic diseases, which identify the issues that are most concerning. So based on the data analysis, we have identified three critical problems here. First, prevalence of chronic disease in seniors. Research from the National Council on Aging indicates that around 95% of adults aged 60 and older have at least one chronic condition, while 78.7% have two or more. Second, rising costs for prescription drugs. Retail prices of prescription drugs for older adults have constantly exceeded the inflation rate annually. As you tell me our data, the annual increasing rate is 9.8% for medication costs, compared to 2 to 4% inflation rate. Shockingly, 1 in 5 older adults in the US faces financial hardship due to the high cost of purchasing drugs. Third, out-of-pocket fees for specialty drugs. Senior patients need to pay a significant amount of out-of-pocket expenses for specialty drugs used to treat chronic conditions. Excuse me. This cost range from $2,600 to over $16,000 per drug, placing a significant financial strain on individuals managing complex chronic illness like cancer. So why do we care? How does it relate to people with different roles? For patients, chronic disease stands as the foremost causes of death and disability. The burden of medication costs often leads to compromised quality of life when patients are forced to cut back on their basic social needs. For healthcare providers, the inability of patients paying for their prescription drugs significantly impact medication adherence. This may manifest in patients rationing medications, delaying refills, or discontinuing medications, thereby altogether affecting treatment outcomes. For policymakers and stakeholders, the financial implications of non-optimized medication therapy are substantial. From a third-party payer's perspective, the annual cost of drug-related morbidity and mortality is estimated to be $528.4 billion, resulting in over 275,000 deaths per year. Addressing the issue of medication costs is crucial to improve health outcomes and reduce healthcare expenditure.
So the current situation that we have right now, should drug prices be determined by market forces or by fair pricing? And the main cause of high cost of prescription drugs is due to four things. One is monopolies, another one is disease severity. A big one is research and development of developing these medications, and the other one is huge lobbying power of pharmaceutical companies. For many new drugs, there is exclusive patent rights, and no other alternatives can come onto the market during this time. So what happens is that these medications run their full life, and when the patent comes close to the end, they actually are considered obsolete. So then a new drug has to be brought in to replace them, leading to this recurring cycle of a new drug and high cost price. Drug prices remain high due in part to the high cost of research in terms of the medication. It can take an estimated from 12 to 15 years for drug development and billions of dollars to even make a drug from a preclinical testing stage, even to make it to human trials. These costs are highly unregulated and provide justification for even higher drug prices as well that the pharmaceutical companies can charge. Proposed opportunities include having fixed or shorter patent times, regulating the drug market towards value-based pricing tied with health outcomes, and actually having groups market for lower drug prices as well, and developing generic drug manufacturers using incentives and lowering the drug prices overall. The Build Back Better Act proposed by the Biden administration includes a provision that allows Medicare to negotiate drug prices with pharmaceutical companies. However, this measure is aimed at lower drug costs of beneficiaries and Medicare program as a whole and selected medications exclusively by leveraging the purchasing power of the federal government. The Medicare Modernization Act of 2003, or the MMA, introduced Medicare Part D, which provides prescription drug coverage for Medicare beneficiaries through private insurance plans. The MMA also included provisions to encourage the use of generic drugs instead of the high cost of brand name medications. And this also establishes a coverage gap or donut hole, where the MMA also takes responsibility for a large share of that drug cost. Another opportunity could be the Medicare Part D redesign. There has been many discussions about redesigning Medicare Part D to make it more affordable and efficient. This would include changes to the benefit structure, such as modifying the deductible, changing the co-insurance, and also covering the donut hole or the coverage gap as well, exploring other options as well.
Okay, now we understand the dilemma. Let's talk about potential solutions. Addressing the monopoly issue necessitates reforming patent protections. Current duration are excessively long, allowing companies to abuse the system by obtaining multiple patents for the same drug to extend their monopoly. To combat this, reforms should curtail over-patenting and system abuse, with deep penalty imposed on pay for delay schemes, where generic competitors are paid to postpone their market entry. Implementing a fixed patent life of 7 to 10 years from initial market entry would encourage generic and biosimilar competition, fostering a more competitive pharmaceutical landscape. Unlike other developed countries, the US lacks in negotiation based on new drugs value, allowing high pricing no matter its benefits. This absence of value-based pricing also weakens other countries' negotiation power, as manufacturers can exploit US price as leverage. To address this, a governmental or non-governmental entity, like the Institution for Clinic and Economic Review, should legislatively empowered to establish price ceiling on clinic value, based on clinic value, and oversee future price adjustments. Pending this, an interim solution involves capping life-saving drug prices to an international benchmark. It is widely accepted that health outcomes of chronic disease patients are multifactorial, including diet, exercise, housing, and lifestyle. However, again, the burden of the medication costs often force patients to compromise on basic social needs, resulting in impaired life quality and health outcomes. Therefore, collaboration among stakeholders from various disciplines is essential, including policymakers, healthcare providers, insurance representatives, and pharmaceutical companies, and patient advocacy groups. Through joint efforts to lower prescription medication costs, stakeholders can positively impact public health, enhance economic stability, and promote health equity.
So what we have here on this slide is our action plan and in terms of taking a four-pronged approach. One option is to use a non-pharmacological intervention, which can look at a lower drug utilization. Option 2 is be a cost-sharing initiative, which lowers moral hazard. Option 3 is developing an incentivized program for patients and providers to use guidelines using value-based medications and prescribing. And then option 4 is looking at more of a transparency option, which has a more robust Medicare involvement into pharmaceutical R&D and cost containment. One study found that those who are 65 of age or older have a serious chronic illness and spend 1,000 to 2,000 more per year on healthcare services than a similar adult with chronic condition. So to deal with that, a possible solution would be to decrease high drug costs is to lower drug utilization by switching away from traditional pharmaceutical interventions and use non-pharmacological interventions in combination. Option 2 involves cost sharing, and in 2020, patients in the US spent $5 million on prescription drugs. Patients with high out-of-pocket costs are less likely to fill their medications, which takes a hit on adherence. So these cost-sharing programs exist across Europe as well and are designed to limit moral hazard. Cost-sharing reform is necessary for chronic disease therapies, and real-world evidence demonstrates that adherence to effective evidence-based guideline-directed therapy increases drug costs, but those costs are offset by lower healthcare costs overall and the downstream effects. The other option would be to incorporate Medicare into pharmaceutical research and design in terms of cost-effective therapies. This would allow Medicare to benefit in interventions that improve patient outcomes and lower research and production costs. And from a patient perspective, patients should be incentivized to take the medications. Patients should identify directly who is going to benefit from the cost of medications as well. This would curb drug adherence and allow patients to offset paying for the medications. And how do we implement this plan? We use a precondition, implementation, and a maintenance and evolution phase. This is a conceptual framework that the CDC uses as well. And it's also called the replicating effective program too as well. The first stage is a precondition stage where we identify barriers, schedule meetings, and track resources over time. The second stage is a pre-implementation stage and involves more direct training, pilot testing, organization, and logistics planning. The implementation stage is implementing the final stage where we get garner support from organizations and management. Then we evaluate the process, and the final stage where maintenance and evolution happens, where we can disseminate our plan, tailored to resources as well. And then in terms of evaluating our impact, we would evaluate annual drug use and in the PUF and the annual cost per user as well. So in conclusion, the average cost of prescription drugs have steadily increased year after year. Taking this three-pronged approach would involve patients, healthcare providers, and policy stakeholders. The Minnesota Claims Department also serves as a valuable resource to evaluate prescription drug costs. But there's still missing some social determinants as well within this database. There are many opportunities to improve the situation from the Build Back Better Act, having capped out-of-pocket costs, which we currently are seeing an effect right now, implementing some cost-sharing strategies in chronic disease states, developing incentivized programs for patients, and then also increasing transparency within the Medicare and pharmaceutical R&D department. Overall, this is a long way to go, but with these bold changes to the US healthcare system, we can substantially improve the overall health of the patients.
Could you explain why you chose to do your analysis as the mean drug cost over total mean out-of-pocket cost?
I'm sorry, can you repeat that question?
Could you explain why you chose to evaluate drug cost growth as mean drug cost, class cost divided by total out-of-pocket cost or mean out-of-pocket cost? What were you doing there? What were you trying to capture there? These.
Yes, I can answer this question. So we look at the outcome indicator as mean cost per user, because it is determined by how much you pay for the drug and how much insurance cover for the drug. So after calculation, we found that this roughly represents the drug price, since this is the money that you pay for the drug and plus the insurance paid. So that kind of gives us the idea of how much is the drug and how it kind of increased annually and how it changes. So that's why we choose.
Okay, so this is your out-of-pocket cost for the total cost of the drug. Might just be labeling, imprecision of labeling.
Yeah, we're looking
Okay.
at the total out-of-pocket.
So it's the proportion borne by the patient.
Correct.
Yes.
Thank you.
Describe a little bit more about the model that you used to do the analysis.
Yeah, so as talked before, it is a multiple linear regression model, because I think this is a appropriate model to use since we're interested in the trends over the past decades about how drug prices changes and how much people pay for the drug, especially targeting the Medicare population, because they're the older patients. And all of these drugs are covered by medication. I would say mostly are prescription drugs, so it kind of fits our interested topic. Also, given that the mean cost per user is non-negative and right scaled, we apply the logarithm transformation to the outcome variable to better capture the distribution. Our analysis focused on the prescription drug detailed database spanning from 2009 to 2020. So
targeting the Medicare population. So that's how we come up with this idea using this model and use these variables to see how it relates to the outcome indicator.
So the raw data were too dispersed to be able to capture
And the-
without the transformation, or what specifically?
So, yeah, looking at the raw data, what happened was that it was just really high drug costs way at the far end. So it was unable to like analyze and capture that information. So what we did is we just condensed that down to just make sure that we have the transformation here of the good drug cost to kind of condense that down so we can see any trends that were happening at that far end as well as at the beginning too.
Yeah, even though we use logarithm transformation, the relationship will not change. If it's increasing, it will be increasing, but it's just a better capture of the distribution.
Want to capture the pricing over time as well.
So how feasible do you think that option 4 is?
Option 4.
It would require legislation.
That's a great one.
It would require legislation.
Yeah. Go back to it here. Yeah, so we are seeing a little bit of Medicare having their hand in the cookie jar right now in terms of having that power of negotiating drug price. But it's very few and far in between of what medications they're selecting. They're selecting just certain medications, very specific medications, and they're not able to select a huge wide range of medications as well that are being utilized. And again, this is where kind of biologics are coming into the conversation as well, that the database wasn't able to capture, unfortunately.
So when you choose to look at drug classes or therapeutic classes, was that a choice of, that's kind of how the data are, and so that was convenient, or I'm wondering if like ideally what, I guess I'm wondering what are the kind of the downsides of that? And I'm thinking about like heterogeneity within those, you know, thinking about generics and brand being in there together, and also thinking about drugs that are for chronic diseases, maintenance drugs that you'll take every day for the rest of your life versus some of the anti-neoplastics that might be for a shorter time period. So just kind of wondering about challenges with looking at the therapeutic class and.
Yeah, there's a lot of information there. So when selecting the chronic diseases, we just pick the most chronic 7 chronic diseases that were available that we can look at within this database. And then when selecting medications, we wanted to look at what are the highest prescription drug in terms of scripts that were being written. And then also wanted to distill that down into what's being covered under the Medicare program as well. And then going from there to see what was coming out at the end when we kind of narrowed that down a little bit too as well. There's an understanding that, yeah, the medications can be used for a short period of time in terms of cancer agents or hormonal agents as well. And then with the medications in terms of chronic use, in terms of diabetes or some of the hypertension as well. We tried to incorporate that into the database to kind of capture both cancer agents, hormonal agents, as well as medications going to be used chronically. And when we did that, we did see, as we pointed out in our database too, that drug prices just increase over time. So I think that was captured pretty much throughout all the drug classes as well. So there's that disturbing trend, despite even generic or brand name medications, that cost is going to be increasing for both. There was limited amount of time in terms of looking at branded generics, but I just wanted to include what was the top scripted medication at that time to see if there was any changes happening.
So if you had more time and more data, what is there like a next step you would do?
Yeah, what's interesting when using this database is it was very upfront in terms of what the cost and what the transaction cost was going on. but it was hard to track down in terms of what was happening on the patient end. In terms of were they actually taking the medication? Were they switching medications in between, year to year or something like that? So there is, what I was looking for is more like EHR data view as well. Would I incorporate this in that and see if it changes in terms of utilization of medications or in terms of cost?
All right, thank you. We're gonna invite team number 14 to come on. And just a tip with the mic, if you're not the one talking, mute it, and we want the orange side to be up. We're all learning. I've never used that yet, but I know this is not like. Yep. Yeah. Yeah, this is literally.
Okay, thank you everyone for taking the time to attend our presentation. I'm Courtney, from the part-time MBA program. This is Ricardo, he's also on the MBA. And now.
Science and engineering.
Science and engineering. So our presentation is on navigating healthcare dynamics, trends in preventative and emergency care usage and use of them. Shift towards prioritizing preventative care services is vital for improving overall health outcomes and also for reducing healthcare costs. Despite this, utilization rates remain low globally, indicating a need for increased promotion and access to such services. Factors influencing utilization extend beyond structural and financial barriers, suggesting need to address demand determinants and to also ensure equal access. Efforts to promote preventative care services must address these multifaceted challenges to effectively enhance utilization and ultimately improve public health. So other factors that affect utilization include socioeconomic factors, and those include income, education, employment, and also healthcare coverage. Race and ethnicity. So with this, we can see language barriers and also disparities in healthcare access. There's also gender disparities, age disparities, along with geographic disparities, obviously within rural versus urban communities. So why does healthcare utilization matter? Investing in preventative care is paramount. By taking proactive measures, we not only reduce disease incidence, but also decrease mortality rates significantly. This not only improves individual health, but also alleviates the burden on healthcare systems. Moreover, effective care utilization plays a pivotal role in curbing relentless rises in healthcare costs. By allocating our resources efficiently, we can ensure that our healthcare system remains sustainable in the long run. This approach will ultimately prevent unnecessary spending and also redirects the funds to where they are most needed. Better outcomes are another significant benefit. When individuals have timely access to medical care, they experience an enhanced quality of life, ultimately leading to improved health outcomes for both the individual and also their community, as they'll be able to be more of a contributing member. This in turn fosters a healthier and more productive population, which contributes positively to the economy, as they'll be able to go to their employment and not be taking days off from work when they're The reliance on timely medical care cannot be overstated. Accessibility and availability are crucial factors here. Additionally, prioritizing preventative care measures ensures that individuals can avoid the escalation of health issues, which can lead to costly treatments and lost productivity. So obviously treating conditions such as diabetes and other issues like hypertension, and making sure they're taking maintenance medications to prevent you from ultimately ending up in an emergency department, which has a significant economic burden. Despite all of those advantages, there are barriers to effective healthcare utilization. There are structural, financial, and demand-related barriers, as well as issues related to equal access, which can hinder individuals from receiving timely and appropriate care. Addressing those barriers are essential to ensuring that everyone can benefit from the advantages of utilizing the correct form of healthcare when it's needed. So for our methods, we use several data sources. We use the Healthcare Services Public Use Files from the Minnesota Department of Health. The Minnesota State Demographic Center provides population estimates for all counties from 2010 through 2022. We also utilize the Economic Research Institute of the USDA, which offered record class data for each county in the nation. For our study design, we analyzed data from 2010 through 2021, and this data was broken out by county to provide a more granular analysis than just state level data alone. County population was used to standardize the number of claims processed. And while analyzing our data, we used both Python and R. And we analyzed the claims by easy code category descriptions, which were emergency department services, emergency room services, office outpatient services, and preventative visits.
So the problem questions we are addressing here is healthcare utilization precisely with emergency preventive related claims associated with socioeconomic, rural or urban population location, race, ethnicity, gender, education, achievement, or age disparities. Granted, that is healthcare insurance coverage filling the gaps on those disparities. If not, what is underneath the market failure? And the assumption is insurance is to fill up those gaps of market failures with what's happening there. And is there a phenomenon or a phenomenon worth attention of or concern at the Minnesota county level, and what is recommended? And we're going to address some of those.
Our preliminary exercise was to look at the average cost of and number of claims coming from emergency room services. We did that by looking at claims marked with the SVC code category description, emergency room services. On this graph, we have the average cost of such claims represented by the bars broken out by payer type, we have commercial in green, Minnesota State healthcare plans in orange, and Medicare in blue. On the right-hand y-axis, that's referring to the number of claims, which is denoted by the lines, which are color-coded the same way. And perhaps the easiest takeaway from this graph is that there was a decline in the average cost of emergency room claims in 2019, although we're not sure what the driving factor behind that was, and we don't really have information to dive into that too much in our data sets that we have. But another takeaway is that across all payer groups combined, the number of emergency room claims has been declining. And that can be good or bad. If people are not being injured to the extent that they need to go into the emergency room, that's fantastic. But if they are being injured to that extent and simply not going for any reason, that's something that should be investigated further.
So it's just data from 2010 to 2021 for emergency claims, standardized by county population. So that we can compare apples to apples, and in both, not significant change from 2010 to 2021, rural usage of emergency claims is relatively higher. And again, we use the county data divided by population. Obviously, if you just get the raw data or the total number, pretty much cluster around the natural area and everything with blue. So obviously we have by amount concentration on the natural area. But here we decided we wanted see patterns and behaviors as one size fits all.
Here's a graph similar to what we had a couple slides ago, but instead of emergency room services, we're looking at the code category for preventive visits. Again, with ours denoting the average cost claim aligns the number of claims. Here we see that for state-sponsored plans such as Medicare and Minnesota health plans, the cost of preventive visits has remained roughly the same over the 11 years we were looking at, while for commercial plans, the cost of preventive visits has increased year over year, while the number of claims for those services has decreased. In particular, between 2015 and 2017, there was a decrease by almost a factor of 2 that was not made up for in claims from other payer services.
Again, we're analyzing data, preventive claims, both also again, 2020, 2010 and 2021. It's the flip side, more urban usage of preventive care or usage and utilization and less rural. And not much change. There are some changes in some counties, but still we can see a pattern along the way from 2010 to 2020.
Our data set does include several demographic factors, so I wanted to look at those to see if there were any trends or patterns in preventive and emergency care use. To get at this data, we split the data first by an SVC code category description, such as for preventive visits, then broke it out by year, by county, and then by whichever demographic we wanted to look at. Once we had it by county, we looked at the number of claims from that county and again divided by the population of that county in order that the large counties don't have undue influence. Here on this slide, we are looking at breakdown by gender. The graphs show data from 2021, but I do want to emphasize that any trends we discuss are prevalent throughout all years in the data set, unless we say otherwise. This is the most recent year we had. On the left-hand graph, we have the average number of claims per county population grouped by RUCA class, which is rural, urban, and commuting codes, and that allows us to group data into 4 categories. On the left-hand side, we have rural, metropolitan, micropolitan, and small town. That makes the data a little more accessible and easy to look at in one graph. Here on we have males in blue and females in red, and we see that females are more likely, balance factor of 2, to seek out preventive care. On the right-hand graph, we see that they also engage with emergency room services by almost the same factor. So I think the takeaway here is that both these services to some extent are voluntary. Hopefully, if you're injured to the extent that you have to go to the ER, you do, but ultimately you have to go there by your own will. And males we see don't doing that. We are not doing that, assuming they're injured at the same rates as females. So it's worth investigating why that's occurring, whether it's stubbornness or a cost aversion or not engaging with their medical lives. Here we broke out data by age in the same manner, grouping by RUCA class again. We see that unsurprisingly, perhaps the demographic for age that engages with preventive services the most, so it's 18 years and under, since that's where you're commonly receiving routine physicals for sports, camps, and other activities, and once you turn 19, suddenly don't have that anymore. So it's fun. But what is surprising is the magnitude of that drop off that happens once you go into the next age group of 19 to 44 years old. In 2021, there were 72% fewer claims when we averaged from county over county population in the 19 to 44 age group than 0 to 18, and similar statistic from 2010 at the other end of the data set was 61%. So that's a disparity that's widening over time. Now, if we look at payer class, we see that only in metropolitan areas is where a plurality of preventive care claims come from those with commercial insurance. In other geographies, there are more dominant payer types for preventive care. One takeaway you might get from this graph is that those without commercial insurance in non-metropolitan areas are not engaging with preventive care, but that's not necessarily the case. If we look at the similar graph from 2014, we see that there was much more engagement in preventive care from those on commercial plans. It's simply the type of payer that has changed. Another way of visualizing this is to look at every county individually, not just by RUCA class. Here on the x-axis, we have all of Minnesota's 87 counties. And we're looking at the number of claims standardized county population broken out by payer type, again, green being commercial, and the counties are sort of descendingly based off of that. One way to look at the geographies of this is to look at the top quartile and the bottom quartile of the data and look at the average Ruka class score for those counties. Ruka class is set up so on scales from 1 to 10, 1 being more urban and 10 being more urban. Or sorry, 1 being more urban, 10 being more rural. And if we do that, we see that the average Ruka class for the top quartile is 3.6 compared to 7.5 for the bottom quartile. So significantly more rural in the bottom. And this data is from 2014, like the previous slide. But if we look at the data from 2021, we see that the average Ruka score for the bottom quartile stayed the same, but it's gone up a little bit for the top quartile. So that means the geographies is the same, but the pair type has changed a little bit. Another nice takeaway from these two graphs is that visually, you can see there's a lot more orange on the right and center part of this graph, meaning that there's been a lot more use of miniature plans between those 2014 and 2021. More broadly, we can say that there's been a spike in the adoption or more directly usage of Minnesota state healthcare plans, specifically in 2016. Over on the left-hand side, we have use of preventive services broken out by Ruka class in 2015, where commercial insurance was most at least plurality of how preventive services were covered. And in 2016, just 1 year later, that was only true for metropolitan and small town areas, and in rural and micropolitan areas, commercial insurance was actually the least common way of accessing preventive care.
This information is just a illustration for one specific county that caught our attention using excessive use of emergency claims. We found that it's Cochise County, and this information is from the Minnesota Employment and Economic Development. It doesn't come from the data set. But one implication or association we can describe here is that education attainment in that county specifically is, if you look at college educated, percentage is 59%, 59.8, and the state is 68.5. So there might be exogenous, obviously, economic factors and behavior, social science. It's hard to describe the exogenous factors, but this is one possible explanation association to more use of emergency claims. The data, this piece of information from the Minnesota Employment and Economic Development also could point to race ethnicity as associated with more relatively use of emergency claims by county.
What we presented was a high-level, time-bounded analysis. So it's quite a bit more low-hanging fruit we could get at if we had a bit more time. One of these would be to look at more granular SVC codes and SVC code category descriptions, which is what we broke down by those just the umbrella terms, and they have some lower hierarchical terms that we can see if any of those are driving any of the trends we saw. Also mentioned a few times there were some trends we identified which we couldn't get at the motivation behind in our data set. If we had some data on uninsured or underinsured individuals who may be more cost averse, that could answer some of those questions. Another data analysis nice to have would be the ability to standardize on age, similar to what we did by number of claims, because the size of the age bins in our data sets are not the same. And age demographics are not uniform anyway. The population of the country skews older, for instance. And another item that would be nice is to compare some of the trends we identified to see if they exist in other states and see if they've identified similar things and how they've rectified them at the listen and learn session.
So key takeaways from the exploration of data: age, gender, and county location are significant factors in preventive or emergency claim counts. Also, demographic features by county suggest, and we saw the information from Minnesota Employment and Economic Development, at educational level, race, ethnicity, and lifestyle present strong associations with that have to be further studied. We didn't have access to the data, unfortunately. We'd love to even ourselves to explore, since everything's already set up for running. Increasing healthcare costs, or healthcare access limitations likely associated with less user-oriented care, especially among the underinsured and insured. And this causes a spiraling cycle of healthcare disparities over time, where higher healthcare costs affect relatively lower income populations more. And those are typically with worse employer healthcare coverage. And one implication, obviously, is healthcare costs is higher, leads to higher emergency care utilization by standard. Those who really have a hard time paying the bills on the preventive side, they just wait to the less as a last resource.
So some of our implications and recommendations that we have, we divided it up by providers, payers, policymakers, government, and employers, employees. So things providers and payers can do are career resources and educational programs that would be available to all patients, encouraging them to seek preventative care and the benefits that they would receive by utilizing those services. We can also have them address supply chain bottlenecks, such as the shortage of providers and nurses, which is going to become an increasingly larger problem in the next few years. We can also address hospital or outpatient healthcare service inefficiencies. So by making your visit more efficient, they would be able to see more patients, which know can be challenging because, a 15-minute visit is already fairly short. As far as policymakers and government, they can evaluate rural-urban disparities in care utilization and potentially create incentives for providers to go to those areas. I know there are already a few programs like that in place, but if they could expand on those, it would ultimately create better care in those communities. They can also incentivize preventative healthcare or healthy lifestyle habits. A lot of health insurance companies have started providing gym discounts, but other ways that they can go further are providing, free or reduced co-payments or deductibles for their plans for those who do make an effort to use preventative care and adhere to the plans that are set forth. Other ideas are to partner with universities so that the number of admission spots for future physicians and nurses are increased. And also in hospitals for the education for those students. I know that can also be another large issue as to why they can't increase student numbers. And then particularly those from a greater diversity of backgrounds. Things employers can do are to encourage healthy lifestyles for their employees by partnering with healthcare providers and payers. They could have larger businesses can have on-site clinics to make it more convenient for their employees to visit those locations. They could also offer their employees half-day PTO to attend their annual preventative appointment. That's always a large barrier for people. They don't want to take time off from work. They don't want to, miss out on childcare. So giving them time to get to those appointments could remove some of those barriers. And also increasing awareness of health as being a multi-layered issue. Health isn't just your physical health, it's your mental health, your diet, your social support systems, amongst other things. So we hope you enjoyed our presentation and learned something from it. Thank you so much for your time.
One more time, how did you distinguish between preventive care and emergency? Was that on place of service code or was that based on place of service? Okay. Two questions then. Did you take into consideration that particularly in rural settings, there are no primary care providers and you use an emergency room for primary care? Particularly if you're a female. Did you look at that?
There wasn't a way to distinguish between that within the data set.
What made you decide to include COVID year data in your analysis? Did you take any efforts to control for that?
We did, we didn't see through the data much substantial on the factors that we're utilizing or analyzing. And we're in some ways puzzled by that. that's something that should be explored. But,
Even the first one, it was precipitous drop.
yeah, it was very, yeah. it was
No, but I mean, that coincided with COVID.
Well, it started in 2019 when I don't think a lot of effects for COVID were around in the US, which is a bit
That
more
dropped,
shocking.
that dropped it. Yeah, it was the emergency room one that struck me. being
Yes,
Obviously, maybe COVID related.
COVID related.
And depending on where those data came in, that might have been the explanation.
But for COVID in the United States, it kind of, we saw more visits starting in like March of 2020.
It just stood out.
Yeah.
I mean, and it was kind of an obvious explanation. I wonder if maybe the reporting features, associated with that particular type of visit might have had some role to play in that. It is paradoxical, though, that preventative care would not have been influenced in a similar way, right?
Now, one thought is that, like certain many people maybe were avoiding emergency services because they were afraid of going there and being exposed. So people really try to
Some questions about your modeling. So there were obviously many factors that went into some of what you observed. But did you contemplate using any sort of dimensionality reduction methods for trying to help us better be able to see and infer what might be the larger factors? And you mentioned things like significance. I don't know that you presented a case for how those were significant other than visibility. Did you model these data in such a way that you were able to statistically determine significance?
I would love to have done, I mean, it's just more timing. I usually had like 10 days. And so I think, that mapping, me myself coming from biostatistics and able to my usually kind of work to kind of mapping that out better and statistically what the causes and associations are, but just time really.
And the weight of these, various factors could be determined with some fairly routine methods.
Yeah.
I'm interested to have seen.
So a big part of what you were looking at, and tell me if I have this right, was like the total number of claims in a geographic area and then the population. So the population that's in the APCD isn't the same as the population who lives in a county. And so did you think about how that might be impacting your, like you mentioned a little bit about the uninsured, but also that big drop in the commercial number of claims from starting after 2016 is a real thing and
it's a data thing.
And it's a data thing. So how did you think about your basic metric and sort of the gaps in the data?
Our main approach was to try to initially group on counties just to make it more aggregated than looking at it on a statewide level. And then looking at it as number of claims per county population helps to do that. Then you still, like when you're presenting it in graphs, it's very illegible to do 87 counties on the bottom. So then averaging, sorting each of those counties into a grouped class and then averaging by that class is what make it a little more presentable. So it's still very high level, but there's many ways to skin a cat, as they say. But our goal is kind of to look at what are some of the discrepancies and patterns in emergency and preventive use care. There's certainly, if you have enough time to talk for an hour about different trends we might find.
Yeah, I'm just wondering if you worried at all that like the counties that were at one tail versus the other, is that really because they're using less healthcare? Or is it because the people who are using a lot of healthcare might not have made it into the APCD for that year?
It's been claimed.
Yeah.
Right.
That's a great question. And I think the data, comes back to the data, what they have more to do that. I mean, we kind of average out, averaging behavior, right? We're kind of putting some outliers here and there, but on average, that's what we want to capture. As an economic behavior or social behavior, so. And that's what we wanted to tap into, and unfortunately, we can go, that level, and that's what we haven't had, but we'd love to, possibly need to, we want that. Yeah, yeah.
So what made Coochin County interesting to you? Why did it catch your eye?
So essentially, it was just because of what we're seeing on the maps. So a very dark red one is it Medina, and then Kuchicheng was up on the.
There's Gucci King and there's Wadena, I believe.
Yep, so those were two that really stuck out to us based on. We're seeing.
So it was the map visual display that made you say Coochin is interesting.
Yes. That was yeah.
But then particularly for Gucci King, on a similar graph for emergency care usage, Gucci King has a very high usage of that, and not so much for preventive care.
It was opposites for easily.
Our judges. Well, I think we'll take a break if everyone needs to use the restroom or get a little water or fresh air for a few minutes, and we'll start again in about 10 minutes.
All right, so good afternoon, everyone. We are Team 13, and we'll get started here by introducing ourselves. So my name is Ingrid. I'm a graduate student in the Integrated Biology and Physiology program at California Medical School, and I'll pass along to my teammates so they can quickly introduce themselves as well.
Hello everyone, I'm Shourabh Kumar Bose. So I'm doing my PhD in electrical engineering. I'm in my second year, and thank you.
Hi everyone, I'm Janushri Datta and I'm also doing my PhD in electrical engineering from College of Science and Engineering. I'm also in my second year.
All right, so awesome. So our team today will be talking about cardiovascular health disparities in rural Minnesota. And we'll be focused on a county called Wadena, which we'll explain why in a little bit. And so to get started, we want to provide an overview of the topics that we'll be discussing. So we'll start out by providing some background information on what heart disease is, followed by some statistics that apply to heart disease in the United States, and some factors that can contribute to increasing your risk for developing heart disease. Once we have a basic understanding of what heart disease is, we'll transition into sharing some relevant demographic information about a rural county called Wadena. And the reason that we are interested in Wadena County is that our team has identified Wadena County as having the highest percentage of cardiovascular disease in all Minnesota. And this has been true for over the past 10 years. So we'll walk you through the methods that we use to identify Wadena County, which include looking at the pharmacological and the health service data that was provided to us for this competition. Then we'll wrap up the presentation by sharing some strategies that we identified from the literature that can potentially alleviate some of these disparities that occur in rural areas, including our area of interest, Wadena County. Alright, so what is heart disease? So heart disease is a general term that's used to include a variety of different heart conditions. In general, some of these conditions you can be born with, while others you can develop throughout your lifetime. There are a few major categories that these conditions can be grouped in. And so the most prevalent form of heart disease are conditions that are associated with the blood vessels. An example of this is the coronary artery disease. And so in this condition, you get a buildup of plaque in the arteries, which provide blood to the heart. And so if this condition is left unmanaged, what can happen is it can lead to what we know as a heart attack. And so this is the most prevalent form of heart disease in the United States. Other major categories include conditions that are associated with irregular heartbeats, also known as arrhythmias. As mentioned earlier, there are conditions that you can be born with, also known as congenital heart defects. There's also conditions associated with heart muscle, and in advanced stages of heart disease, you can get heart failure. And so research has shown that many forms of heart disease can be prevented or managed with proper education and proactive lifestyle measures. And so currently in the United States, heart disease is the leading cause of death. And this is true regardless of your biological sex, and for the most part, aside from your racial and ethnic makeup. And so as of 2021, 1 out of every 5 deaths in the United States is associated with heart disease. And what's more alarming and morbid is if you take a look at the total number of deaths per year, it comes down to 1 person dying every 33 seconds in the United States due to heart disease. And aside from the emotional burden that's associated with heart disease is very expensive. In a single year, it costs the United States $239.9 billion, and this cost included healthcare services, medicines, and loss of productivity time due to death. And so Dr. Natalie A. Bayo, who's a physician and the director of hypertension research in the Schmidt Heart Institute at Cedars-Sinai Hospital, she states that approximately 80% of heart disease is preventable. And so this may prompt you to ask, what are the factors that contribute to increasing your risk for developing heart disease? And so to answer this question, we have to look at the social determinants of health. And so what's included within the social determinants of health are an individual's economic stability, the neighborhood and the environment that they are a part of, the quality and the accessibility of healthcare and education, and the social support and community relationships that this individual may have. And so someone who faces adversity in any of these factors, this can lead to chronic psychosocial and or environmental stress. And these stressors, they have adverse biological consequences, meaning that these stressors, they can activate pathways that can promote chronic inflammation in the body. And chronic inflammation is well known to increase risk factors associated with cardiovascular disease, such as obesity, hypertension, diabetes, atherosclerosis, all of which can lead to adverse cardiac events and, in severe cases, mortality. And so there are certain communities or populations that tend to encounter more adversity. And so for our presentation, we'll be focused on rural areas. And so here we have a map of Minnesota, and the rural area we'll be focused on is Wadena County. And so here we indicated where Wadena County is in Minnesota. And to give you some more perspective, we also included the county where the University of Minnesota Twin Cities would be. And if we were to take a drive from our current location to the public health department located in Wadena County, it would be a little bit under a 3-hour drive to arrive. And once we arrive to Wadena County, what we would learn is that Wadena County is your standard rural area. It has a small population of 14,241 individuals, and this is based off the most recent census. If we take a closer look at this population, what we learned is that it's, in regards to ethnicity, it's pretty homogeneous. So 95% of the community identifies as white, 25% are over 18 years of age, and another 20% are over 65 years old. If we look at the biological sex profile, approximately half are female and half are males. In regards to the educational level, 92% have at least a high school diploma, and 18% have at least a bachelor's degree. Looking at the median household income, it stands a little bit under $55,000 per year. And other aspects of this community that we wanted to highlight were access to technology and healthcare services. So in regards to access to technology, about 82% of the community owns a computer with internet services. And in regards to healthcare services, there are 2 major healthcare facilities within this county. And what we also learn about this community is Wadena County has the greatest percentage of cardiovascular disease in all Minnesota. And so this leads us to the following 2 questions. What are the factors that are contributing to this increased prevalence of heart disease in Wadena County compared to the rest of Minnesota? And how can we address this public health concern? And so I'll pass it over to my teammate Sarah, who will walk us through the methods that we use to identify Wadena County.
Thank you, Ingrid. So I'll cover the data analysis approach, and we have used the healthcare service data and drug summary data which are provided to us for this competition. So we have vital information such as county, sex, age group, current procedural terminology codes, which is known as CPT codes in service data. And in the drug summary data, we have vital information such as drug classification, information on prescription and uses of different types of drugs over the years. We have also used the population data from Minnesota State Demographic Center to find the percentage of people affected by a certain disease rather than depending solely on raw patient number, which could be misleading. We have used the data from 2011 to 2021 for our analysis. For data pre-processing, we have focused on the most used drug from the drug summary data and then matched it with the CPT codes in service data. Then we did the disparity analysis based on age group, sex, county, and rural-urban commuting area code, which is known as RUCA code. We also used regression analysis in order to find if there is any trend in the data. And based on our results from disparity analysis and regression analysis, we have identified that the county Wadena has the most most CBD affected population. And then we tried to find the root causes behind that. Based on the possible causes, we have proposed some solution strategies which can contribute to policy intervention.
I'm sorry, what were you measuring? Were you measuring in counters or dollars?
Sorry.
Were you measuring in counters or dollars? And counters, claims, number of claims, what were you measuring?
The number of unique number of patients.
Unique number of patients, thank you.
So from our drug summary data analysis, we have found that the cardiovascular agents are the most prevalent pharmacological agents used in Minnesota. And you can see over the time, it has been consistently one of the top pharmacological agents used by the most number of people in Minnesota. So from our analysis on cardiovascular diseases in service dataset, it became evident that there is a significant difference between the number of people affected in urban areas and in the rural areas. The difference was around 1% in 2011, whereas you can see the difference is around 8% in 2021. So you can clearly see that the gap is widening over the years. So then we have focused our attention on the rural or town areas and looked at different counties' CBD patients. And we have found that Wadena consistently stood out as the county with the highest percentage of CBD affected individuals. And every year you can see Wadena is the topmost. And however, the counties with lower percentages showed more variability over time. We have also done the trend analysis over the years and observed that CBD prevalence is rising across most rural counties. Here, and here. And however, some of them, a few counties show decreasing trend. However, Wadena has the highest percentage of CBD over the time, and the trend is on the rise. You can see the trend was in 2011, it was like around 45%, and in 2021, it is like almost 60%. So we narrowed down our attention specifically to the county of Wadena. Now my teammate will talk about age group and sex disparity and the root cause behind that and strategies to resolve this healthcare challenge.
Thank you, Saurav. So we have done some demographic data analysis. So from the analysis, we found that the incidence of CVD is increasing with age among older adults in the county of Wadena. And this trend is also rising over the years. We've also done biological sex-wise analysis, and for most of the years, it is observed that females are more likely to be affected by CVDs compared to males. And this is true for most of the years, and this trend is also rising over the years. So, while traditional research suggests that females have less incidence of CVD compared to males, recent studies tend to challenge this notion. And this aligns with the findings that we have from rural Minnesota, specifically in the county of Wadena. So in Wadena, white females who are of 65 years of age or older have the highest percentage of CVD highest percentage of cardiovascular disease. Although among the age group of 40 to 60, among males and females, this ratio almost equals out. But elderly females over the age of 60 have higher prevalence of CVD compared to males. But only around 56% of females recognize that heart disease is their primary cause of mortality. This is alarming because that's only about half of the females. Most of the females think it is breast cancer. And also this is more concerning because females have a higher risk of silent heart attack because their symptoms are significantly different from those observed in males. So we tried to find what could be the causes that Wadena County has higher prevalence of CVD compared to other counties. So we found out 4 key factors. And lifestyle choice, poor lifestyle choice comes out as a key factor. We have found out that the residents in Wadena spend significantly less on fresh fruit or vegetables or like a healthier diet compared to the state average of Minnesota. Also have found out that the smoking rate in Wadena is about 22.5%, which is higher than the US national average of 20%. Also have found that the poverty in Wadena, that is also a significant factor, and that is also rising over the years. We also know that some biological factors like diabetes and obesity are some known precursors to cardiovascular diseases. And the rate of people affected by these biological factors like diabetes and obesity in Wadena is also high. Last but not the least is the access to primary care. So in Wadena, we have found out that the primary care practitioner to patient ratio is poor. And we have specific data for that. In Wadena, there is one practitioner for 2,030 patients compared to the Minnesota state average of 1 practitioner to 1,130. So, and we have also found out that this ratio, this trend is worsening over the years. So we have tried to provide some strategies based on statistical or existing knowledge for all these 4 factors. For poor lifestyle and biological factors such as diabetes and obesity, the policymakers can organize public health campaigns for promoting the importance of healthier diet and physical activity. They can also promote health education. And one other strategy could be to collaborate with local farmers market so that the residents can have more access to fresh produce, and they can make it more affordable. Then the factor of healthcare practitioners. So one strategy could be implementing telehealth, and we have found out that in the year of 2012, in International Fall in Cochise County in Minnesota, they did a study on patients having congestive heart failure, and they found out that the patients who used the service of telehealth had 4 times more access to practitioners compared to those who didn't. And this also gave benefit to them in terms of out-of-pocket cost. So this could be a potential solution. They could also establish mobile clinics, and we could also have better recruitment and retention strategies and allocate more resources. So for socioeconomic factors such as economic situations, collaboration with community stakeholders can be a very good strategy. And for the overall development of cardiovascular health in Wadena, the most important thing could be to have more resources for dedicated research, specifically for demographic specific data, because we have seen that females have more prevalence of CVD compared to males, and maybe have more research grants and allocate more resources. On top of the strategies that we have just shared, we are also proposing a data model-based approach that where we can have a regression model that can have inputs from annual records of healthcare data from healthcare providers. And with this regression model, they can give out different outputs such as analyze trends and also forecast different metrics such as percentage of CVD affected people or like demographic specific data. And with this forecast in hand, the policymakers can do targeted interventions. And also they can measure whatever measures or steps that they have taken the previous year to tackle this challenge. How are they affecting, if there is any change that these steps have brought? And this will be a very powerful tool. Lastly, we would like to thank you for hosting this interdisciplinary health data competition. Thanks to the judges, thanks to the organizers, and thanks to the audience for being included. Thank you.
So do you have any thoughts about some of your suggestions? Your suggestions are great, but some of your suggestions are kind of magical thinking. So how do we allocate more resources? Have you given any thought to that? Or how do we allocate more research grants? Have you given any thought to that?
So we actually, if we choose to pull up the slide here. So there are already a plan in place in Minnesota. There's called the Minnesota 2035 plan. And in this plan, they have objectives that they're trying to figure out by 2020 or 2035. And so they've laid out a roadmap of the strategies that they're going to try and implement to meet their objective. And so, for example, here, one of the goals that they have is to ensure all people have access to resources and supports needed to prevent disease and promote health and well-being. And so their strategy is to try and provide reimbursement policies and payment structures for health services such as telehealth. So there's already an infrastructure that's in place. We would just be further supporting that.
Can you go over the data again on what data exactly says Wadena County has the highest cardiovascular disease incidence? Yeah, so how did you calculate that?
So from the the data, service data, so we mapped the cardiovascular agents with our CPT codes. So the CPT codes are the range is given here. So we use this range to to find the CPT codes related with the cardiovascular disease. And then based on that, we have the county information and how many unique number of people or patients have taken that CPT service. And then we got the number of patients. And then we have the population data. From the population data, we divide that with the total number of population in one. That's how we got the percentage.
Thank you.
You mentioned significance a few times, and I didn't hear a discussion about the model. It's like in that figure that there's a significant increase in disparity. Visually, I would agree with you, but did you do any type of analysis to sort of confirm that statistically?
Analysis based on existing statistical data.
That's correct.
Yes, so one of the things is that like Wadena County has is in the list of four, is placed fourth, top four, which has the number of people dead caused by heart diseases. So, and also it is one of the top counties having the number of older adults suffering from CVDs. So from our analysis findings, and we have also tried to search for like a statistical data of the most updated years, and they kind of match of what we found from our analysis.
So no, I mean, so there wasn't, you know, as far as these data are concerned, it was primarily observational that you come to say
Yes,
that there's a significant difference.
yes, we have, yes.
Did you consider using E&M codes instead, or just the cardiac CPT codes, the evaluation and management codes, since a lot of cardiac patients would be going in for regular care and not have a cardiac procedure?
Yes, but the thing is that in our data set, we had CPT codes in the service data set, and but no counting information in the drug summary data. So we kind of had to match the CPT codes from these two data sets, and then we
To answer your question, we need more information, like the CPT codes for regular checkup or like for a
Yes.
particular disease.
Okay.
But we don't have that.
Okay.
yes.
Other questions? All right. Seems well. So you're muted, right?
Hello, everyone, and thank you for joining us today. Before we begin, I just want to say it was really cool seeing everyone's presentations and what everyone found from the data as well. I'm really glad to be able to use the all pairs claim database as well. Today, my name is Tanvi. I'm a second-year PhD student in the Health Policy and Management program, and I'll give it to my teammates to introduce.
Hi everyone, my name is Jia Yi. I'm a second-year master student in biostatistics.
I'm Lexi, second-year MD PhD student.
Yeah, also a second year I'm a student in biostatistics.
Thank you. Today we are going to be talking about evaluating cost-saving potentials through substituting high-cost generics for lower-cost generics in the state of Minnesota. In the United States, 90% of prescriptions are generic medications. And by one estimate, use of generic and biosimilar drugs in place of branded drugs resulted in a savings of $330 billion in 2020 alone. Generics make high-value, effective medications affordable. However, current market dynamics may not incentivize the lowest cost generics on the formularies. In order to understand why, we must look at pharmacy benefit managers, also known as PBMs. You may have heard of these entities anywhere from a congressperson to Mark Cuban. PBMs are intermediaries who negotiate prices and formulary placement for health plans, and they're usually the middlemen between manufacturers and insurers. They engage in strategies such as copay clawbacks, spread pricing, and profit-oriented formulary design that may lead to the overpayment of generic drugs. There is increasing evidence that suggests that there may be overpayment for these generic drugs.
And one study found that Medicare Part D standalone plans paid $2.6 billion more in 2016 for 184 common generics compared with prices paid by cash-paying Costco members. While generic drugs represent a small share of overall healthcare spending, they are often the only interactions patients will have with the healthcare markets. This highlights our need for evaluating cheaper substitutes where they exist for overpaid generic drugs, especially in a time where high costs are on the minds of states as well as patients. Our research question that we set out to answer for the competition was, how much can payers and patients save if high-cost generics were substituted for low-cost generics of the same therapeutic value in the state of Minnesota?
Our study utilized the Minnesota all-payer claim database prescription drug detail public use file of year 2020, focusing on the top 1,000 generic medications with the highest total spending. The selection of data from year 2020 exclusively was due to the cross-sectional nature of the study, which utilized the most recent data available. We chose not to conduct a longitudinal study given the unavailability of many generic drugs in earlier periods. Three criteria were used to match the high-cost generic medication with the low-cost therapeutic alternatives, which include same dosage, different manufacturers, different dosage, same manufacturers, and different dosage and manufacturers. Across all three criteria, the matches have same active ingredient, dosage form, and insurance coverage. The table shows one example of matching within each matching criteria. For the criteria 1, medications were matched with the same dosage and different manufacturers. The example given shows there were two pregabalin 150 mg capsule having different manufacturer under the Medicare insurance in the dataset. The higher cost capsule is from Dr. Reddy's laboratory, having a per capsule price of $0.86, while the lower cost generic drugs come from the Novartis Pharmaceuticals, having a per capsule price of $0.75. For criteria 2, the medications were matched with same manufacturer and different dosage. An example here is a hydroxy HCl tablet from the AV Pharmaceutical under the Minnesota healthcare programs. The higher cost tablet is 10 mg, having a per tablet price of $0.13, whereas the lower cost tablet is 100 mg, having a per tablet price of $0.18. Therefore, in order to obtain the same strength of 100 mg, we will need 10 tablets for the 10 mg medication with a price of $1.3, much more expensive than a single tablet of the 100 mg. For criteria 3, the medications were matched with different dosage and manufacturers. Here is an example showing the acyclovir tablets under the commercial insurance. The higher cost medication comes from the AV Pharmaceuticals with a per tablet price of $0.836 for a 800 mg tablet, while the lower cost generic medication comes from the Chemo Pharmaceuticals with a per tablet price of $0.15 for a 400 mg tablet. To evaluate the potential cost savings, we conducted a comparative analysis of the pricing data between the expensive generic drugs and their therapeutic alternatives. The analysis was performed at unit level, utilizing transaction price per individual tablet, capsule, or milliliter. To ensure an accurate comparison, in cases where the therapeutic alternatives require different dosing or administration compared to the high-cost generic, appropriate adjustments were made. Specifically, if a therapeutic requires multiple units to achieve the same therapeutic effect as a single unit of the high-cost generic, the price of the alternative was multiplied accordingly. For instance, if 2 tablets of the therapeutic alternative were needed to substitute for 1 tablet of expensive generic medication, the price of the alternative was doubled. The adjustment ensures that the pricing comparison reflects the equivalent therapeutic impacts, enabling a fair assessment of the cost-saving opportunities through the substitution.
Excuse me, where did you get the pricing for the alternative?
Sure. So you're asking why?
So you said 2 tablets of the alternative equals 1 cost of the high cost generic. Where were you getting the pricing for the alternative?
Yeah.
all the pricing are in the detailed drug sheets. So here, this is specifically by matching the dosage.
Okay,
So, we want the therapeutic value to be the same, want the dosage to be
okay,
the
so you took it from the data
same.
and you
Yes,
took, and you used as the alternative, the lowest price for that molecule.
Yes.
Okay.
I employ this rigorous unit-level pricing analysis and making necessary dosage adjustments. We aim to provide an accurate representation of the potential cost saving attributable to the strategic substitution of higher priced generic drug with the more cost-effective therapeutic alternatives. We calculate the insurer saving, patient saving, and total saving by payer type for all three criteria. Here's an example formula we use to obtain the total saving for each product under certain criteria. The per milligram price is calculated as the per unit price divided by strength of the unit. Proportion of saving equals to 1 minus lowest per milligram pricing match divided by a higher milligram pricing match. The total saving for each product under certain criteria equals to the proportion of saving multiplied by the total cost of the product.
So moving on from the detailed method shared earlier, we now spotlight the cost saving opportunities found in switching to different generic drugs. A wide range analysis looked at the variety of generic drugs available in Minnesota's healthcare setup, seeking to identify which could save money and what that might mean financially. Our analysis, visualized through a pie chart here, titled Number of Alternatives for Single Different Manufacturer, presents key findings. We can see that mere 3.9% of our studied medications posted a selection of over 10 alternatives when it comes to sourcing the same dosage from different manufacturers. The category of 6 to 10 alternative matches was more robust, incorporating 17.9% of our dataset. Most notably, considering 55.2% of the medications could pivot between 2 to 5 manufacturer alternatives, hinting at the potential for substantial cost adjustment. Conversely, for 22.9% of the options, the market presented only a single alternative, signaling a limitation in choice and the potential cost savings. The number of alternatives for same manufacturer with different dosage, alternatives exceeding 5 matches was scanned, representing just 2.7% of our findings. A considerable 47.1% had the flexibility of 2 to 5 dosage alternatives, suggesting moderate variability. Surprisingly, the majority at 50.2% had a single dosage alternative available, posing questions about the diversity of cost-saving options. And from the pie chart on number of alternatives for different manufacturers and different dosage, you can see that a healthy 22% of the medications surveys present over 10 alternatives, indicative of our vibrant selection range. The 60 to 10 match range accounts for 18.6%, while notable 39.3% sit comfortably within the 2 to 5 match range. However, a not insignificant 20.2% are cornered into a solitary alternative, spotlighting areas where market competition and potential savings are limited. In the quest for cost efficiency, our analysis pinpoints significant savings through the substantial high-cost generics. For the commercial sector, savings from manufacturer alternatives amounted to $85.9 million, with dosage alternatives contributing another $54.8 million. On considering both manufacturer and dosage alternatives, the total savings potentially escalates to $124.4 million. Medicare sees even more pronounced benefits, with manufacturer alternatives offering savings of $145.8 million, dosage alternatives $113.3 million, and the combination of the two reaching a striking $230.2 million. The MN healthcare programs are also stand to gain, with savings of $57.2 million from the manufacturer alternatives, $48.5 million from dosage alternatives, and $89.8 million when both are applied. Insurers across different sectors can also significantly reduce expenditures. The commercial insurance sector could see savings of $48.3 million with manufacturer alternatives and $29.8 million with dosage alternatives. A strategic combination of both could lead to savings of $69.9 million. Medicare received $107.4 million and $80.9 million with manufacturer and dosage alternatives respectively, soaring to $167.5 million with a comprehensive approach. MN healthcare programs might realize savings of $54.6 million and $46.2 million respectively, with a total potential reaching $85.6 million when combining both strategies. Patients too benefit from these substitutions. Commercial patients could save $37.6 million and $25 million with manufacturer and dosage alternatives respectively, and $54.6 million when both are leveraged. Medicare beneficiaries could save $38.4 million in savings from manufacturer alternatives and $32.3 million from dosage alternatives, with combined strategies yielding $62.8 million in savings. Participants in MN healthcare programs could save $2.6 million and $2.3 million respectively, with total savings of $4.2 million when employing both substitution strategies. So in summary, substituting all identified alternatives could yield over $440 million in total and $320 million in savings for insurance and $120 million for patients in Minnesota alone. This analysis underscores the potential financial benefits of increasing generic Medicare substitutions. By advocating for cost-effective alternatives, both insurers and patients can achieve significant savings, highlighting the importance of informed decision-making in healthcare cost management.
So in conclusion, strategic therapeutic substitution represents a promising approach to optimize healthcare costs while maintaining the quality of care. The study provides robust evidence of substantial saving opportunities by addressing the overpayment of high-cost generic drugs. The finding can inform formulary design, procurement strategies, and broader efforts to restrain the rising healthcare expenditures. And beside the implementation of the Inflation Reduction Act's Medicare drug pricing negotiation program and the prevailing drug market dynamic, which encompass insurer strategies and profit-driving formulary design, there persists a pervasive lack of consistent prioritization for the most economically advantageous options. The study highlights the significant opportunities for cost savings by substituting expensive generic medication with therapeutically equivalent lower cost alternatives. The finding underscores the need for systematic evaluation of drug formularies to identify high-cost generics that can be substituted, leading to substantial reduction in medication expenditures. These implications are highly relevant for healthcare payers, including insurers, employers, government programs, and individual patients, as they can improve the affordability and access to essential treatments. Furthermore, the study encourages greater scrutiny of pricing practice by pharmacy benefit managers, addressing potential conflict of interest and lack of transparency that may contribute to the overpayment of generic drugs. And building upon the study, further research should expand the analysis to encompass a broader range of therapeutic classes and generic drugs. Additionally, developing decision support tools for therapeutic interchange program can facilitate the identification and implementation of cost-saving substitutions in clinical practice. To improve the PBM market, the researchers recommend increasing competition by using business models that commit to price transparency. Employers and the government should also have audit rights that allow them to review PBM transaction and prices. And from a policy perspective, advocating for changes and industry reform is crucial to enhance the transparency in drug pricing and supply chain operations, while aligning the incentive to prioritize the inclusion of cost-effective medication for formularies. And here's our reference. That's up for our presentation. Thank you for listening, and we're
In the beginning, you did a very good job in terms of sort of providing some context and because I'm not familiar with this work, if you could just maybe state again where you were building from. There was there was some previous studies that you mentioned that had similar interests and similar questions. You just state that or maybe emphasize where you're building from.
Sure, yeah. So, I guess one of the studies that I had talked about, they showed that the Medicare Part D plans, the standalone plans, they paid $2.6 billion more in 2018 for 184 common generics compared with prices paid by cash paying Costco members. I guess the motivation for this project was like PBMs, when they decide to put drugs on formularies for insurers, they get a certain cut of how much they're able to negotiate and get the rebates back. And so they're like, it's a incentive problem, because if they're getting more money back, they probably want to negotiate more rebates, leading to higher cost drugs being on the formularies. And so that was kind of the motivation.
Yeah,
Does that
yeah.
kind of answer your
That absolutely answers the question.
Okay.
Yeah, thank you.
I'm not aware of any PBM that actually works with the supplier of the drug. Generally, when they're listing their formulary, they're listing a molecule name, particularly because there can be all kinds of reasons why a supplier can't supply that drug anymore. There can be import problems, supply chain issues, contamination, whatever. Have you looked into whether or not that's actually accessible, whether this is feasible to do this?
Whether it's feasible. for
Feasible to
PBM.
dictate Dr. Reddy. We're gonna dictate Dr. Reddy's, that's the only name I remember from being up there. Dr. Reddy's generic is going to be the only one we're gonna pay for.
I think PBM data is very, very secretive. I don't know that I haven't been able to find it online. So, I mean, this information for me comes from other literature.
Sure.
I personally have not taken, like, I don't have access to see what PBMs put on, help put on formularies. So I personally would not know that information.
And you're right that, you know, what's missing and missing in the APCD is the whole rebate, so you don't know what happens there. But my question is kind of related, so because you've got like the doctor who prescribes the drug, you have the pharmacist who fills the prescription, you have the patient who goes in and gets it, you've got the insurer, the PBM who pays for it. Whose job is it then to make better choices, or, you know, who, at what level will this work?
Who has the control?
And the answer is not the patient, because we already asked too much of patients. They can't, you can't add more to them. So is it, how do we make it work?
That's a good, very good question and point. I think one of the solutions that we highlight is increasing transparency in how certain drugs are on formularies. And I think just transparency in general would help people anywhere from, not patients, but like providers, insurers, as well as people in Congress help come up with solutions that can broader address that problem. But you're right. I think there's just a big incentive problem that we have in that area, that we just wanted to highlight through this project.
No, and I think you're, like, transparency is a really important piece of the puzzle and a really important first step. But when you get to the, now what do I do with it? And some transparency efforts put it, you know, treat the patient as the consumer and the shopper as if they're buying a car. And it's too complicated, you know, so, yeah, and the provider writing the prescription might not know. You know, so it's like, how do you get the right information? It's a huge challenge, but by seeing the impact that it could have is, you know, again, it's an important step in the process of making things better.
Some questions about the data.
So I think definitely from your perspective, asking like which step should we take? I think as a clinician, like physician,
point of view, especially now we are using EHR to prescribe drugs. I think having like the AI or like the those implementation that when we are prescribing a drug, we can see the prices, what the patient have to pay, and then listing the alternatives on the patient's perspective can also give us an option to provide the best option and also the most affordable option for the patient. I think, so that's on the physician perspective, but also the price, it's not, physician can control the care, but we couldn't control the price. So the price have to be from the, like, here we are saying it has the transparency. So the PBM, the pharmacy, and the government, they are the control piece.
2 questions about the data. What were the years included? I didn't see that on any of the graphs. What years did you include in that?
So we choose 2020
You chose
alone.
2020.
So this is the most recent data we have. Again, we are doing now a longitudinal study, we are doing a cross-sectional study.
Yeah.
Because many of the generic drugs were not available in earlier
Sure.
periods.
Okay, so 2020. And then the second question I have is, did you at all try to normalize the data? You report your savings in total. You have very different membership in those plans. There's no surprise to anybody here that the highest dollar amounts are in Medicare, because that's the target market for prescription drugs. So did you do anything to try to normalize so that you could make those comparisons more meaningful and do statistical tests of significance? Or just the reported total?
So here we are breaking down by commercial and Medicare and Minnesota healthcare programs, and that's the only available categories from the data set.
Okay.
Any more questions?
Ask one. I was just you offered some solutions about the smart Cuban, pharmacy and directs, and are those valid options for consumers or kind of the programs to save costs? Have you looked into that?
That's a really good future direction for sure. I mean, I think Cost Plus has like the plus 15% markup from acquisition cost. And so they don't go through any PBMs. In fact, like, I don't know if you've seen, but like his interviews with anyone, he says, all those PBMs, and so I think if patients know about it, if there have been instances where patients' co-pays have been more than the generic prices of generic price of drugs itself. And those co-pays may be even more than buying it from Cost Plus. So that is definitely a really good.
No, that's exactly. So one of my friends is the CEO of a company called Direct, DIRX. It's a direct to consumer, and they have a supply chain coming from mostly kind of valid FDA kind of sources outside of the US. And they are providing supplies of medicines which are lower than the co-pays for many patients, Medicare patients. And so that's what I was confirming.
But it is illegal for a pharmacist dispensing the drug to charge more than the cost of the drug. So they will pay the lesser of the copay or the cost of the drug.
That's where the transparency piece is there, correct? We don't know. I think that's the whole, but you're right.
Thank you. Okay, so from this point, we're gonna let the judges do their deliberations until 6:45. We have a reception set up on the second floor, food and beverages for everyone to enjoy. You can mingle while the judges are deliberating. So the easiest way to get there is the elevator right outside the door. Take to floor 2 and the room is 2-245. And judges, if you want to go up and get a plate